In this video lecture, we'll be reviewing the symptoms of psychosis. So when we're discussing psychotic disorders and psychosis, we're talking about a set of disorders that are characterized by alterations in perception, cognition, and behavior. And these changes are characterized by a state called psychosis, which is a mental state involving a loss of contact with reality. Another way of thinking about psychosis is that an individual is unable to distinguish between their internal subjective experiences and the objective external reality that exists in the real world. So in psychotic disorders, we see major shifts in perception, thought, and actions that indicate that an individual is experiencing a discrepancy between what they are internally and subjectively experiencing and external reality. We can divide our symptoms of psychosis into two broad categories. The first category are our positive symptoms, and these are positive in the sense that they reflect an excess or distortion of normal function. So they're not positive in terms of being perceived as good or helpful, but rather they are positive in terms of adding something on top of normal functioning. So we are either adding an excess of functioning, or we are taking functions that exist in a normative state and distorting those existing functions. The other broad category of symptoms are the negative symptoms, and these reflect a deficit or a loss of normal functioning. So they are negative in the sense that we are taking away from typical functions. We'll start out by discussing the positive symptoms of psychosis. And our first symptom are delusions. So delusions are beliefs that an individual holds to be true or believes that are inconsistent with reality. So delusions have a couple important characteristics. So one is that delusions are false. They are false beliefs. They are not consistent with reality. They are fixed, so they stay stable, and they are not responsive to contradictory evidence. So even in the face of evidence or information that goes against this fixed belief, an individual in a state of psychosis will continue to hold that belief. It's important to recognize that delusions should not be classified as delusions when they reflect commonly held cultural beliefs. So rather, these are not only false, but they are also inconsistent with an individual's culture. Delusions are often categorized on the basis of the content of the delusion. There are a range of common types of delusions. For example, delusions of grandeur involve believing that you hold special powers or are particularly important. So these might be beliefs that you have some kind of superpower. So for example, that you are telepathic, or believing that you are the reincarnation of an important historical figure. Another common type of delusion are persecutory delusions, where an individual believes that they are being targeted by harm by a person or an organization. So for example, a belief that you are being tracked by the CIA, or that there is a group that is out to get you. So a common way of characterizing delusions is by talking about the content of these false beliefs. Our next positive symptom is hallucinations, and hallucinations are sensory experiences that an individual experiences in the absence of the appropriate and relevant sensory input from the external world. And often we characterize hallucinations based on the sense that is being affected. So we can have auditory hallucinations. This is when a person hears something in the absence of those sound waves from the external world actually hitting the ear. We can have visual hallucinations. That's when someone sees things that are not actually out there in the world. So perceiving something through sight when you don't have those light waves bouncing off of things in the environment and hitting your retina. You can have olfactory hallucinations, so smelling things in the absence of scent molecules getting into those receptors in your nose. You can have gustatory hallucinations, so this is tasting things in the absence of molecules in the mouth being sensed by those taste receptors on the tongue. You can have tactile hallucination. These are hallucinations that occur on the skin, where you sense feelings on the outside of your skin when there is nothing on your body. A common example of a tactile hallucination, common, for example, in individuals who have ingested hallucinogenic drugs, or things like cocaine are tactile hallucinations of having bugs crawling over your skin. And a related but different kind of hallucination is somatic hallucinations. So these are hallucinations of internal sensations in the body. So for example, a hallucination that your intestines have turned into snakes, or that organs inside your body have disappeared. Those are somatic hallucinations. So these are subjective sensory experiences that are not accompanied by the appropriate external objective stimuli, and we characterize them on the basis of what sense they are affecting. Our next positive symptom is disorganized thought or speech. So psychosis can be characterized by disorganized thought, and we can describe this on a spectrum ranging from what we call loose associations, where a person's thoughts are kind of related and we can see how we are getting from one thought to another, but it's a little bit harder to follow. We're getting a little bit disorganized. A little bit more disorganized than loose associations would be tangential, when a person's thoughts are going from one to another and they are not really associated, but you can at least kind of imagine a path from one thought to another, all the way through kind of fully disorganized thought, where an individual's thoughts do not appear to have any kind of logical or coherent association to one another. And one of the ways that we assess this disorganization of thought is by observing a person's speech. So we assume that if a person's speech is disorganized, that is reflecting underlying disorganization of their thought and cognition. There are a few different ways that we can observe this commonly in speech. One is neologisms. This is when a person is inventing words and using them and expecting people to understand these words, even though these are not words in any language, in a language that they speak, in a language that their audience speaks. So kind of inventing these words. Another way that disorganized speech can manifest is something called clangs. So this is when a person starts using words not because they are semantically related to one another, but because they sound similar. So for example, it might end up having kind of a sing-songy, rhymey Dr. Seuss kind of tone to it, where you're hearing a lot of rhyming words, but the words are connected by the sounds in the words and not because they are conveying something that is semantically meaningful. And at the most severe end of disorganization, speech can sound like what is often characterized as word salad. So this is when you have speech that is grammatically intact, but that semantically is not conveying any meaning. So if you've ever gotten a spam email that was generated by a computer program and you could read those sentences and you read them out loud and it sounded like a sentence that could exist in English or whatever language you were reading, but that didn't actually make any sense, that those words could go together in a sentence but didn't mean anything, that's word salad. So you have words and sentences that ostensibly, could have meaning in a given language, but that don't actually have any coherent meaning. So these are all ways that someone can manifest disorganized thought in an observable way through their disorganized speech. And in addition to disorganized thought and speech, our final positive symptom is grossly disorganized behavior. So behavior that is unusual or erratic. One particular kind of disorganized behavior is called catatonia. So catatonic behavior is behavior that is unresponsive to the environment. One kind of catatonic behavior we'll classify as a positive symptom, and that is catatonic excitement. So this is when we have an excess of behavior. So we might have agitation or an increase in behavior in a way that is unresponsive to the environment. So the person's agitation and their behavior is not in reaction to some kind of interaction or to some kind of stimulus in the world, but their agitation and their disorganized behavior is internally generated. That brings us to our next set of symptoms, the negative symptoms. So remember that these negative symptoms represent a deficit or a loss of normative functions or behavior. And our first negative symptom can also be a form of catatonic behavior. So catatonic behavior that is unresponsive to the environment in a way that reflects a decrease or loss of behavior would be characterized as a negative symptom. So one way that we can see this is catatonic negativism. This is when we have a notable decrease in behavior. At the most severe end of catatonic negativism, we might have an individual who is not engaging in any voluntary behavior. So they might be lying down or sitting completely still and not engaging in any voluntary behavior, not reacting at all to their external environment. And in this catatonic negativism, sometimes when you look at a person's muscles, you will notice some unusual muscle behavior and differences in kind of voluntary physical movement. So they might be very rigid, they might be sitting or lying in a particular position and not be moving unless a person takes them and physically moves them, and you might experience some resistance when you attempt to move them. And you might also notice some laxness in their muscle tone. So for example, if you pick up the arm of an individual who is experiencing catatonic negativism and hold it up and support it at the wrist, you might notice the fingers and the hand kind of pointing downwards, just kind of dropping, not being held up. You might experience holding up their arm, you might feel that weight, you might have to hold it up for them. So this catatonic behavior, this catatonic negativism, is suggesting a loss of behavior, a deficit of behavior, that their behavior is not responsive to the environment in a way that is suggesting a deficit or a loss of functioning. Another negative symptom, we can see deficits or losses of affective experiences and affective expression. And we call this affective flattening. What this means is that we are seeing either a restricted range or intensity of emotional expression. And just like with disorganized speech, we assume that that disorganization of speech is representing an underlying disorganization of thought. When we see affective flattening expressed through someone's facial expressions, we are assuming that that is reflecting an underlying subjective experience where the range of emotions that a person is experiencing is decreased, or the intensity of emotions that they're experiencing is decreased. So you can observe this by looking at someone's facial expressions. If you are seeing facial expressions that appear not to be consistent with the emotion that a person says that they are experiencing, they might have kind of a very neutral facial expression, or if facial expression is not changing in ways that you might expect. So for example, in response to external circumstances, in response to conversations, you might characterize that as restricted range, or at the kind of total end of the spectrum, you might see what we call flat affect. So this is when a person appears to have no emotional expression, no emotional responsiveness. So again, we can see this as a range from restricted, where we are seeing less intense emotions and seeing fewer emotions expressed, all the way through totally flat affect, where we're not seeing evidence of kind of any emotional changes or differences in emotional intensity. Another domain that we can see affected in negative symptoms is speech and language, and we call this alogia. So alogia refers to decreased fluency or productivity of thought or speech. So again, here where we're seeing decreased fluency or productivity of speech, we are assuming that this is an external representation of the internal subjective experience of decreased fluency or productivity or thought. So this might be a slowing of thought and speech. Someone's speech might take a long time. There might be long pauses. You might see decreased fluency, that you're getting fewer words, 1 or 2 word answers. And at the most severe end, you might see a complete absence of speech. People might not be responding at all verbally, or might have very, very minimal verbal responses. And then the final domain of negative symptoms is avolition. So this is another behavioral negative symptom, and avolition refers to a lack of goal-directed behavior. So this is a bit more severe and a bit more pervasive than we saw in depressive disorders with anhedonia. So with anhedonia, we saw a loss of pleasure, a decrease in behavior, and that decrease in behavior could become very pervasive, but often it's characterized by particularly a decrease in pleasurable behaviors and things that people used to enjoy. In avolition, we are seeing kind of a universal decrease in goal-directed behavior, and these can be kind of very important fundamental behaviors, things like basic hygiene, keeping one's clothes clean, keeping one's body clean, feeding oneself, keeping oneself housed. So really seeing a decrease or an absence in goal-directed behavior that is pervasive and unusual.